Thank you very much. Ladies and gentlemen, welcome to today's web seminar. We're glad you could join us for new care delivery and payment models demand new data sources and insight, the art of the possible. I want to take a moment to acknowledge and thank our sponsor for this program, Nexus Risk Solutions. We appreciate their support. Today's program will feature two guest speakers who have substantial insight and experience in the healthcare industry. First, we're going to hear from Rick Ingram, who is the LexisNexis Healthcare Director of Vertical Markets with a special focus on the health delivery and payment sectors. Rick has more than 36 years of experience in the healthcare industry, providing thought leadership, vision, strategy, product development, and brand awareness skills. Rick will be joined by his colleague, Jim Payton, who is the Director of Strategic Solutions Consulting for LexisNexis Healthcare. Jim and his team work closely with the sales organization to drive new business development and bring solution subject matter expertise into the sales process. He's been with LexisNexis for almost 5 years, serving as a subject matter expert with specific focus on provider data intelligence solutions. We're fortunate to have both Rick and Jim with us today, and in addition to their presentations, they're going to take questions from you at the back end of this program, as you heard, so we hope to be able to cover a lot of ground on this program. So with that in mind, let's get started. I'd like to turn the proceedings over to our first speaker, Rick Ingram. Rick, the floor is now yours.
Thank you, Mike, and welcome everyone. I hope you'll find today's content informative and helpful, but perhaps more importantly, thought-provoking. Both Jim and I are committed to empowering the healthcare community with approaches that both support improved effectiveness, but also nurture innovation. And we hope that today might lay the groundwork for continued conversations, and our direct contact information will be provided at the end of today's session. Within the time boundaries of this webinar, we have a lot to share with you. Our Art of the Possible session is intended to challenge you to consider approaches and data assets that may have heretofore been ignored. Indeed, as Bob Dylan sang out, and as many healthcare will attest, the times they are changing. We'll kick off by putting a bit of perspective around the challenges facing the healthcare industry, and for providers especially. And we'll broaden the dialogue to suggest the need to consider expanding insight into the care continuum by turning to new data sources. Now, more importantly, we'll suggest traits that we view as required to succeed, and who might make a partner artist, if you would, to help you with that. We will share with you activities that LexisNexis Healthcare has been working on to provide you with an artistic palette and that we feel is important. And within this context, we feel that provider networks can really impact even further the triple aim of improving care, improving patient experience, and lowering costs. So as Mike said, please don't be shy about posting questions, and we'll get to as many as possible toward the end of the hour. So let's get started. One more note before I change slides is I began to build this with kind of a view of the healthcare issues that we address in everyday fashion. But I couldn't help recall some quotes over the past 5 to 7 years that have really stuck with me. Like when Dr. Brent James, the Chief Quality Officer at Intermountain Healthcare, observed that 15 to 20% of care is clinically inappropriate. Or when the New American Foundation Health Policy Program released a statement saying 30,000 Medicare recipients die each year from care they didn't need. But perhaps more salient to this audience is in just 2015 when the Deloitte head of the life sciences and healthcare practice observed that 10 years out, the relationships between providers and health plans is going to be drastically different if provider-sponsored plans prove to be a superior model and they can do things that health plans just cannot do. So with that, along these lines, I thought I would share with you that what I and many of my other colleagues have been actively discussing and exploring ways to really attack healthcare quality costs and experience long before and since the Affordable Care Act. We see, and despite this artistic depiction, we see these 7 challenges along with federal and state mandates that are not for the faint of the heart. So let me quickly touch on each. Now, purposefully, I've placed at the center patient engagement, or the ability to better align information and services and activity focus on the needs of the patient, the consumer of healthcare service, as well as the family caregivers. There's an overall recognition in our industry within the care payment and delivery sectors that the more patient-specific we can make our communication and programs and services, the higher the likelihood they'll be seen by the patient as valuable and something they become engaged in to seeing to completion or even adopting as lifelong practices. And more engaged the patient is, the more likely they'll impact adherence and the provider-linked quality measures. Care payment models are probably the most controversial topic today. They represent new approaches to provider payment and reimbursement driven by the need to increase outcomes and results associated with care, rather than continuing payment for services regardless of service outcomes and quality. Often referred to as the shift from fee-for-service to fee-for-value or value-based reimbursement. They might include bonuses or withholdings and penalties and payment as a result of a prior period's care performance. Macro initiatives, now referred to as quality payment programs by HHS, includes merit-based incentive payment systems and advanced alternative payment models, where the pressure is for all providers to choose heading into 2018. Care delivery models are fast-growing, and in fact, though equal in terms of size, if not more, in terms of the number of non-provider-sponsored plans, the market share is still pretty lagging for the provider-sponsored plans. Often directed at improving care quality, coordination and results, or business risk sharing, examples include models that are not limited to accountable care organizations and patient-centered medical homes, but also are now being addressed via retail point-of-care centers and digital physician diagnosis pods and walk-in clinics for non-critical care. Times are changing in both how we deliver care, how we use information to deliver care, as well as, except for one, the patient needs to be at center. Potentially avoidable health conditions. Conditions over costs is the recognition that many health conditions or procedures may have been avoidable if proper or more efficient and appropriate care protocols have been followed, coordination and engagement and timing of intervention had been adhered to. An analytic discipline to identify specific stages within care where avoidable conditions arise is now growing nationally, but this requires a discipline to go beyond diagnosis to treatment data and include other factors that impact health system performance, basically effectively ensuring that the right medical care is delivered the right way to the right patient at the right time. I think we all have agreed that that's always been our purpose. As the system becomes more convoluted with federal and state mandates, it will become even more difficult to demonstrate the performance is clicking on all cylinders. Integrating mental and behavioral and personal health, which focuses on a 360-degree view of a patient care profile, really crosses the personal medical care to include mental and behavioral health care intersections. And finally, but not lastly, the use and misuse of health data, securing the personal identity of the patient and their care record, ensuring that all appropriate health data is leveraged to ensure improved quality of care and to make informed decisions. Now, a little bit about me. I'm a big fan of Dr. Atul Gawande, surgeon, writer, and public health researcher practicing at Brigham and Women's Hospital in Boston. And he was quoted recently as saying, "We look for medicine to be an orderly field of knowledge and procedure, but it is not. It is an imperfect science, an enterprise of constantly changing knowledge, uncertain information, fallible individuals, and at the same time, lives are on the line. There is a science in what we do, yes, but also habit, intuition, and sometimes plain old guessing. The gap between what we know and what we aim for persists, and this gap complicates everything we do." Well, these challenges aren't simple, of course, and I would suggest that a mindset must be on a quest to close the gap, gain certain information, and rely more upon additional data sources and less on plain old guessing when possible. Mike, I think it's time for our first polling question.
So we do have our first polling question, and the question is, how have new care delivery and payment models impacted your business? So you have 3 available choices. You have greatly, somewhat, and not sure. And please select the radio button that best corresponds to your answer, and then hit the submit button. Again, the question is, how have new care delivery and payment models impacted your business? Greatly, somewhat, and not sure. And we'll just give it a few seconds to allow everyone to vote. Okay, I think everyone's had a chance to vote at this point, so I will now share the results, and you should now be able to see the data.
Well, I don't think I see a surprise in this at all, Jim. I mean, as we look over the past 4 years, the whole concept of care delivery and payment models have gone from interactive, yes, we need to do something about it. I can remember sitting in New England 15 years ago talking about the dangers or the practice patterns that fee-for-service created, but actually moving into models where there's mandated care delivery metrics and payment and quality outcomes metrics is a whole new game. And I think really what it's causing providers to do is say, I've got to do something other than what I was trained to do, which is to treat, diagnose, and provide additional treatment. Now I've got to really look at the business functions of my operation.
Right.
So what does it take for the art of the possible? And what does it take for the artist? Well, creativity and innovation are certainly what we all might say are critical when considering the art of the possible. But let's not lose sight of the objectives. In looking back at how models of operations have emerged, I think a provider standing at a canvas would be wise to consider several things. Stay true to the medicine. In this case, providing optimal care to a patient both in and outside of the traditional diagnosis treatment scenario. But this must leverage your training, but also challenge you to learn along the way, perhaps by including new information points never used before. And understand the payer perspective. What is medically necessary in the eyes of a payer? How are the costs associated with care analyzed and looked at? How is proactive engagement becoming more and more important rather than waiting for the 80% of people driving, the 20% of people driving 80% of costs just filing a claim? And finally, if you're not part of an integrated health system, force yourself to begin to consider how the business model is different. You might even find that step 2, which I purposely put before step 3, is critical to that step. And finally, consider what it would mean to bring your organization to assume risk. What would it be to become one of the provider-sponsored health plans? What are you going to do when you're asked to move into 2018 and select an alternative-based payment model? Now, once you put yourself in this mindset, then you kind of ask yourself, what do you need to really capitalize for the art of the possible? And I would suggest focusing on insight. It can be incremental or massive, but it's always a step forward in being prepared for whatever shifts the industry might take due to either government mandates or entrepreneurial advancements. I ask that you consider internal insight first. Tear apart your organization and look for new points of insight in terms of how things are working and where perhaps gaps in communication with patients may be existing. And then look for insight around relational perspective. Where do you fit within the marketplace? And then begin to think about competitive perspective if all organizations are part of provider-sponsored health plans and at risk. Finally, begin to look at how are your quality metrics and your finances correlated. What do you need to maintain financial solvency? And understand that shades of performance are really degrees of change longitudinally, and the detail around that can help you make very impactful changes in your operation and even staffing models. Now, while touching on the various requirements I see as critical to drive innovation, or art if you will, I recognize that each of those viewpoints and insights desired is extremely complicated, and in fact many spend their entire careers in search of these goals. So what does it take for the artist to be successful when we just can't afford to take too much time before actually taking steps toward change or operationalizing what we've learned? Either you must build internally or partner with an organization that offers vast and relevant data, an analytic discipline, and the ability to leverage the two into intelligence that drives changes. Jim, you work with healthcare organizations every week, striving to help them get to this point. What have you observed, or can you share about these 3 areas?
Thanks, Rick. I think what I see that most organizations, healthcare organizations, understand that they need more insightful data, but they struggle to get it right for many good reasons. They understand that there are lots of relevant data sources that are out there in the market that need to be pulled together, But to make the data work and to really understand the data requires the ability to link that information and make it available and make it trusted, a trusted source across that organization. Many organizations may have siloed development of databases. For example, the analytics department may build a database to drive their analytics, but that database is not complete enough for the department that needs to outreach to physicians and create those relationships. And the data that the outreach department needs to contact physicians is not deep enough for enrollment or does not fulfill the needs for analytics. So it requires healthcare organizations to build a source of truth that can be used across the organization. And that's no easy task. Healthcare organizations are generally not equipped to do this well. And of course, LexisNexis has been in the business of bringing together data to solve business problems for over 40 years. So we kind of understand it. It starts really from the data perspective and being able to bring together all of that data and be able to do it in a way that can make that data useful and drive insights. Each source of data has good information and sometimes not so good information. And it's hard for an organization to understand what's good and what's bad in a source of data. What data is relevant from that source. The best processes out there will take each source of data, standardize that information, parse it into elements that will allow you to do the best possible job of matching that record to your referential source. The process uses rules-based or deterministic type approaches. It can use predictive or probabilistic matching type approaches to link records. That would be which records look like they may match each other. And it really should leverage all of the elements that come in on a record to do the best possible job of matching. And the best process is going to utilize a referential database to match against, so that if you have two records from disparate sources, you may be able to create a match by bridging those records together across the referential source to be able to link those two records that you may have within your particular organization. So it takes the ability to look at each element, match those elements up to your referential file, and then be able to essentially calculate the value of the match across all those elements to make a determination whether you have enough elements that match to consider that record a match. And then you can add that record as part of the provider's profile, or you can use the referential data to essentially to validate, cleanse, or augment that input record and return a good record that's complete for that particular provider or for that particular record. And a persistent ID is very important in this process to be able to create a historical view of that individual entity, either the person or the entity, so that you can tie all of the disparate bits of data to that individual to be able to recognize change over time and be able to have a centered point or a point of center where all this information can kind of come together. Then the effort is using this linked data to drive actionable intelligence. Domain expertise is required to be able to understand best practices in leveraging this data across different use cases, what rules to put in place to drive the actions that you're going to take, what anomalies should you expect to see in the data to be able to clean up those data elements as they come in, and how do you make the data accessible to all the different applications across an organization where that data is needed. So the effort is to start with the most granular information on a practitioner or a provider, and then be able to use that information to be able to intelligently aggregate that information to the organizational level to get that complete picture. For today's discussion, we'll focus primarily on provider data. Obviously, there's a lot of different types of data that come to play here. Provider data being one of the critical areas that's hard for organizations to get right, and it's for good reason. We know managing provider data can be challenging. Having correct, current, and comprehensive view of a provider is essential to many of the operational and strategic initiatives that a healthcare organization has. We know that managing this data is difficult. In fact, that's why Nexus has literally invested several $100 million to be able to approach this challenge on behalf of healthcare. We understand that the nature of a practitioner is very dynamic. Some of the statistics in the upper left corner of the slide bear that out. This is data that you can read in publications. It's data that we see in working with customers across healthcare every day. Practitioners change their demographic information at a rate of 2.4% every month. 30% of doctors change their affiliations during the year, so they may add to their practice, they may change their practice or hospital affiliations. And doctors' status changes at a rate of 5% per year as well. So all those changes together add up to 30 to 40% change across the provider continuum. And on top of that, the pace of business and the processes that healthcare organizations utilize to manage provider data tend to exacerbate these problems with multi-channels, with hand data entry or manual process that bring provider into the focus. So at a holistic view, if you started today with a completely clean view of your provider data, if you didn't have a process to keep that data up to date, within 18 months, half of your information would be bad or incorrect. Think about what that impact would be on your organization if half your data was bad. So how do we stay ahead of this change to help our customers stay ahead of the change? How do we keep errors and inaccuracies from corrupting your data and causing inefficiencies and misinformed decisions? It requires a very diligent effort to compile this data that gives providers information on providers' credentials, status, their attributes about the practice, their demographics, the current information about that provider, and a view into their activities. What do they do in the marketplace? This is really the art of creating a provider master file. It starts with the base data, acquisition of data from the key sources out there, sources like license boards, drug enforcement agencies, CMS, NTES, the Social Security Administrator, the sanctioning authorities. For all of these sources, they're authority sources for certain credentials, or for the credentials that you get from these sources, they are the authority sources. So when we bring in information on a provider and we want to give that provider the correct NPI, we're going to leverage NTES, which is the authority source for NPI, to be able to assign that data. And linking of this information then to your provider profiles is going to be the key effort. Medical claims is another great source of data. It's a rich source of information on where a provider practices, how often they practice there, are they active at that location, and it also allows us to create additional views into a provider that we'll talk about a little bit further as we move forward in this presentation today. Another key to building provider master file is sourcing of data from multiple sources that are available in the marketplace through what we call harvesting, which is accessing network rosters, publications around participants in ACOs and IDNs, and being able to then affiliate the organizations to those parent companies. It requires a targeted data acquisition strategy to get data elements that are relevant and important to the healthcare market, such as board certifications or professional email addresses. And it requires an updated approach that allows you to stay current with this data. So we like to bring in data from all of these various sources, and there's over 2,000 sources we're talking about here. It's getting data from those sources and bringing it into the master file when those sources make that data available, so you have the most current view available. Because as we said before, those provider demographics, those statuses change very, very frequently. Another approach is really to enhance the provider master file is direct outreach to the providers. So to proactively reach out to providers to get the latest information or to fill in the blanks of information that you might want to know about that provider, or to use outreach channels to verify information that you might see from some of your sources where there may be a discrepancy or there may be something new that you want to verify to be able to bring it into your master file. That requires a multi-channel approach that doesn't use just email or just phone call, but it could use faxes and other methods that allow you to maximize the response that you get from providers. At LexisNexis, we also like to embrace the consortium model, and a provider data consortium is enhanced or is essential to our master file solutions. And that consortium allows us to leverage the almost 70 healthcare payers out there, most of the large payers in the marketplace, to recognize change much faster than we're going to see it from the other sources that we mentioned on the slide. So as a provider updates a payer with new information, we can see that change and then look across all of our sources to look for corroboration. And once we see more than one source with that data, then we can also direct verify that information through our proactive outreach and multi-channel outreach to bring that data as a verified element into our referential database. A good data model also requires data stewardship to be able to do research and resolve potential discrepancies that you might see in data or across data sources. It must provide the ability for a customer to provide feedback as they see changes or as they enroll a new provider to be able to get that information into the system and updated very quickly. And of course, it requires analytics to drive the linking of all of those data sources to help determine the hierarchy of which data sources may take precedence over another data source, and be able to do things like score demographic information that does not have an authority source to say, based on recency and frequency and sources, how confident are we that this information is good for that particular provider. And all of this, of course, requires real-time big data platform to be able to manage that information in a way that makes it useful and accessible to the organization.
Thanks, Jim. I have to be honest, there are times where I think of being in a provider setting and wondering, why do I need provider data? I'm a provider. I know who I am. But I think that the salient point is how things have changed. I want to bring your attention to the very top statement. More payers trust LexisNexis than any other provider information solution. That's critical. Remember my advice about thinking like an integrated health system or an IDN? Remember about my advice about thinking about what would assuming risk mean to your business, how you would grow or wouldn't be able to grow, how you test your financial solvency? Remember Deloitte's observation about provider-sponsored health plans? If you do, why would you not be interested in the same intel, especially when you're working to build a relational and competitive understanding of the environment you live in? So it's critical that the breadth of data around providers be available to providers as they begin to move into new care delivery and care payment models and want to grow by enhancing and bringing in additional physicians to meet the needs of coordinating care and a population of health. And so it's time to explore a bit. An artist's palette is a thin board of slab on which an artist lays and mixes colors, the range of colors used by a particular artist or in a particular viewpoint. In our case, let's look at the various colors of data and data approaches that a provider organization, big or small, might leverage. Given the world of new care payment delivery models, any additional viewpoints or insight can make a difference. Mike, I think it's time for our second polling question.
Yes, it is. Thank you, Rick. So, ladies and gentlemen, we're going to have the second of our 3 polling questions right now, and we'd like to hear from you on this question. Are you looking to non-EMR data sources to impact your business? And your answer options are often and from many sources, too many distractions to think about more data, or the EMR gives us enough. So once again, are you looking to non-EMR data sources to impact your business? Often and from many sources, too many distractions to think about more data, or the EMR gives us enough. particularly like Rick's comment about the palette. Data sources now are not only so many, but are also so varied. The palette is a great metaphor for that. So let's go on now, and let's take a look at the responses, and we'll continue with the rest of our program. So overwhelmingly, we can see nearly 71% of you responded that you are looking at non-EMR data sources to impact your business often and from many sources. Rick and Jim, does that surprise you that it's that high? Because that is a very significant number.
You know, I have to admit, it is higher than what I thought. I think having spent some time at HIMSS last week, and we did a focus group with providers, I think where we need to drill down into this is, the good thing is care delivery models and care payment models have just forced providers to say, business isn't as usual, so what else can I do to help myself run this organization? I think the real challenge is most organizations I've talked with have said, we're interested in things like social determinants of health. We're interested in understanding provider referral patterns within our region or within our state or within our specialty or by disease. But it's an awful big task to then integrate that into operations when we're also busy with the electronic medical record. The good thing is, I would venture to say, that 2 years ago, the focus on the EMR was taking so much attention that even to have a conversation about other data sources was basically a non-starter. So I think this is a good sign for the industry, but it's not for the faint of heart, and we've got some work to do. And with that, I want to talk about, Jim, the provider data intelligence suite that LexisNexis Healthcare has been further expanding and can enable really new pictures of understanding and reliance upon facts. When you rely upon facts, you're taking the guesswork that Dr. Gwande mentioned away. So Jim, I'm going to turn it over to you.
Yeah, thanks, Rick. I mean, I think the provider data intelligence suite is really built, I think, to solve the challenge that providers have, healthcare organizations have, on managing the right data, right? So there's a lot of different data sources out there. We can help them bring that information together and then present it in a way that meets that particular organization's, level of sophistication, right, or where they are. Fill in the gaps to be able to clean up and make sense of the data that they are bringing in through our particular solutions. So we look at provider data intelligence really as a continuum model, as the diagram shows there with the stair steps. Stair 1 is really delivering a relevant subset of that provider master file that we've painstakingly built on providers across the United States market, and being able to provide the healthcare organization with a trusted source of information that provides that complete view of a provider with correct and current information on that provider and that provider's profile. So it's helping you create a source of truth that you can use internally. Stair 2 is really enhancing the data that you have. So taking in your information, cleansing it, and augmenting it from our referential library of information about providers so that you can have a complete picture of accurate information on the providers that are in your provider master file. The third stair is providing validation on your data. So at the point of entry or in a real-time access, being able to allow you to do research on a provider or validate the information you have on a provider or a practitioner before you enter it into your system, or once it's in there to be able to make sure the information you have is correct. And the fourth stair in the continuum is Agile data management, which is the outsourcing of the data management functions to help you create a provider master that can be used across your universe. And we'll talk more about that fourth stair as we move ahead here. So there are many reasons to consider the Agile data management stage of the process. As we talked about already, managing the many changes in healthcare practitioner data is very challenging. There are many inputs, many touch points of that provider data. How do you create a golden record, a single golden record that can be leveraged across your enterprise That can be especially challenging to have that golden record. And certainly a single misstep here can cause far-reaching problems. Think about it as if you have a directory error and you send a patient to the wrong facility, or you have the wrong information in aggregating providers in your analytics, and you make the wrong decisions based on incorrect analytics. So it's important to get this stage right in your organization. In most healthcare organizations, using complex data management and data stewardship is not a core competency. This is something that obviously LexisNexis does for a living. We've built it as a core competency. Most organizations do not have that available. So what is Agile data management? There are really three major components to Agile data management. The first is the engine. That's the platform and the data warehouse that ingests and stores the provider information, and it makes the data available to your organization. So it puts it in a format or in various formats that are accessible to different applications for provider data across your organization. The next stage is the analytics that provide insight into that data. How accurate is that data? We talked about the confidence scoring before. How many sources verify that that information is correct, or which sources are you getting that data from so you know it's the right information? What's the best data for the particular use case? If you're looking for best addresses or phone for contact, or you're trying to determine best specialty, you need analytics to determine what is best from the various data sources. Or how do you determine what's relevant? You know, what's the provider's relevance for the particular use case? What's their experience level? How far are they from the opportunity that you're trying to point them to? And then the third piece of the Agile data management product is the services that provide additional abilities to enhance the data. It ensures that you get the value that you expect out of that particular system. So we're consulting on how do you best use that information within your organization. Or building rules around how do you associate a provider to an organization, or developing custom campaigns or custom approaches to update or enhance the information within the engine. Next slide really is talking about sort of the process flow. I won't spend a lot of time on this, but the idea is that we're taking your input information, data that you have built up over history, data you might get from third parties. We're combining it with the information that LexisNexis brings to the table in our master referential database, built from claims, public records, our provider data warehouse from over 2,000 different sources. And it puts it into an Agile engine that really ingests and standardizes and links this information together, and then provides a user interface to take advantage or to leverage the information that's within that referential library. And then we can add services on there to enhance that data, go out and get additional data variables that you may need specifically for your organization. And really the whole aim is to drive towards analytics that you can use to make better decisions within your environment. So provider data analytics, who does what, where, how often, clinical analytics that might help you drive better outcomes in your patient community, and other analytics that will help you aggregate information across your provider community. And then being able to deliver the data in a way that meets the application, whether it be a real-time API feed of data into some other application, like a directory or enrollment, or a batch process that might feed analytics or other departments. And claims is a very significant component to an Agile data management strategy because claims can provide a lot of insights that you wouldn't get from other sources, particularly looking at where does a provider practice, who do they practice with, what sorts of activities do they have at that point of service. And really what claims gets you to is a current view of what types of behaviors or activities does a provider or practitioner practice.
Thanks, Jim. Mike, I think we're ready for our third and final polling question.
Okay, very good. So ladies and gentlemen, as you heard, this is our third and final one. We'd like, again, to get your thoughts on this question. What comparisons are you most interested in? Is it how my performance compares with previous years, how my performance compares with my peers in our practice, or how my performance compares with other providers in my region or specialty? We know that healthcare providers and their organizations obviously are very focused on performance for any number of reasons. So tell us which performance metrics you are most interested in. Once again, is it how your performance compares with previous years, how it compares with your peers in your practice, or how your performance compares with other providers in your region or specialty? Okay, I think we're going to move ahead now, take a look at the results of this one, and take us home. And again, overwhelmingly, we see 75% of you believe that the comparison you're most interested in is how your performance compares with other providers in your region or specialty. Rick, again, any thoughts on this one?
I love it. I mean, that's exactly what I believe that the state of the industry should be. I think the fact that we've had conversations for the better part of a decade of the need to switch from fee-for-service has kind of driven that from a standpoint of, okay, what do I actually have to deliver and what is being delivered in the region? But I think more importantly is perhaps providers are basically realizing that to grow, they need a lot more information, not just about providers in general, but specific providers in specific regions and specific specialties to address adequacy of coverage. There has been a shortage in primary care physicians. There has been a shortage in some regions for some physicians to be able to be there on the spot, so new care delivery models are also being asked for. So let's move on. Thanks, Mike. So, and Jim, by the way, thanks for your observations about the Provider Data Intelligence Suite, especially Agile data management. Now, you mentioned just before the polling about getting a current view of the provider behavior. In the limited time left, let's share a bit about a solution we call Market View and its capacity to provide some deeper insights into the provider community, including fellow peer providers within a larger organization or even a gain-sharing agreement. We recognize that there are many facets to how a health system grows. Actually, these may vary even more so now with new care payment models and forcing provider communities to examine their operations at the new dollar at risk value-based reimbursement models. Because of our vast data assets, Nexus Healthcare can empower providers and health systems with claims-based intelligence about their own organizations, as well as competing organizations that are providing care and influencing care. Physician alignment strategies are critical in ensuring patients receive the full care coordination and follow-up required of an at-risk provider operating either through an ACO gain-sharing agreement or as well as the new emerging quality performance programs. This alignment is facilitated by enabling an understanding of opportunities for physician outreach, limiting or eliminating system leakages by identifying referral patterns, and those high-volume practitioners by diagnosis or procedure, and how to improve overall health utilization. This alignment is critical for the provider organization to grow smartly with focus of need and within at-risk agreements. Now, I mentioned LexisNexis Healthcare vast data assets, and this includes the industry's largest physician-level medical claims warehouse. 12 months of just slightly more than $1.3 billion of claims, where 75% of that is actually updated monthly or even sub-monthly, like bi-weekly. 1.4 million practitioners, and the part I'm particularly excited about is 190 million practitioner relationships. These relationships will be critical as organizations look to add more additional bench strength to take on the additional burden of coordination of care and making absolutely sure that outcomes are maximized as well as revenue. I think you can quickly realize how this information is critical in understanding the market that an at-risk organization must operate in. But also, what does more breadth of insight mean in terms of coverage of all major care settings? More in-depth knowledge of insight more flexibility of insight, delivery mechanisms that power enterprise-wide analytics and applications. All of these can allow a provider at a level of insight of their own financial sustainability. Simply put, this insight drives client-defined service and procedure line strategies. No longer must you look in the rear vision mirror with your own organization to try to determine what or where you will be down the road. Being able to leverage the art of the possible approach by customizing your own palette view, mixing in colors encompassing diagnoses, procedures, care settings, patient demographics, and volume levels across the largest physician-level claims warehouse in the industry can mean a custom roadmap for your own growth and areas of need for improvement. Furthermore, this view enables a deeper understanding of physician and facility relationships tracked longitudinally. This ability can position a provider organization to anticipate pushbacks from plans, as well as lay out a risk mitigation plan addressing specific care scenarios.
Thanks, Rick. And this example really kind of shows this off. It's really an example of physician activity volumes at a procedural level, in this case, the metastatic breast cancer. And it's looking at that at a relevant geography to the healthcare organization, using these to determine which providers have the highest impact to that healthcare organization. And using claims data gives us some unique insight into what's happening with the provider. It gives us, in conjunction with our master referential database, we're going to know specific details about that particular provider, what their specialty is, what networks they belong to, and so on. And then allows us to use that claims information to get an idea of where they rank amongst their peers in your region for seeing patients and providing these types of procedures. So you can essentially get a picture in your community of which providers you should be most interested in talking to, whether it's be recruiting or bringing into your organization.
You know, I think it's also important to realize that market view allows us to really identify relationships. So where procedures are split across a multitude of different facilities, understanding that relationship is critical as you try to grow your at-risk provider community. Also, with the procedure splitting insight, understanding the loyalty factor is critical, but also the physician influence in terms of networks, being able to understand and identify the referral sources and possible sources of system leakage. And finally, because we're running short on time, the ability very quickly to understand who is the best potential candidate to reach out to that will provide a care delivery mechanism that your current provider organization cannot meet in terms of either demand or network adequacy. So it provides an outreach, integration, and recruitment tool. Jim?
Yeah, and just in conclusion on that, MarketView is really built with the foundation of our provider master file. So it combines that claim data with the very accurate and complete view of providers that we've built in a provider master file. It'll take the information on your physicians and practitioners. It'll use that claims information to help draw affiliations between those practitioners and the organizations where they practice and who they practice with. And then we can use our other master data to roll those organizations up to the parent organization. So is that organization part of an integrated delivery network, an ACO, and so on?
I want to leave some time for questions, and it's a frustrating battle to share more information, but yet time just doesn't permit. I think it's important to realize that we started this hour addressing 7 significant market pressures that the care provider community is facing and cannot ignore. So rather than going through it all in detail, why don't I just ask you, in terms of patient engagement, how would adding new data sources and insight change the way you communicate with a patient? How would you change your staffing roles to better align with patients' needs? Within a care payment model, how could competitive insight into provider space help you negotiate? And how would you limit the financial exposure within those additional data sources? Within care delivery models, how could insight with patients' social determinants of health empower a better way to outreach and also staff and change staff workload? What practice patterns impact errors? And how can we really expect overall performance using the same data sources, even if electronic? Finally, in terms of health data use and misuse, always stay vigilant in regard to data security. But how vigilant are you when it comes to data not leveraged to improve your operations or data not sought? Finally, let's not forget the journey both the payer and provider community have taken. More and more new business models are recognizing the importance of a 360-degree healthcare view, views that require an understanding of patients, costs and claims, success of outcomes of care, and provider adequacy and makeup. As the care payment and delivery models continue to evolve, one might argue that we are doing a disservice in separating the two when healthcare must first be centered on the patient in ways that push the payer and provider communities to think and act as one. I started and I'm going to finish with Dr. Gawande. He said that culture has tremendous inertia. That's why it's culture. It works because it lasts. But culture strangles innovation in the crib. Wow. Well, a 360-degree view healthcare society or organization may be in its infancy, but let's not strangle innovation at a time when we need a new culture of data expansion, reliance, analytics, and intelligence. Mike, I think we've got just some time for questions, so let's open it up to what you've got.
Okay, great. Thank you, Rick and Jim. I think we're going to just take one or two from our audience now. So let's start with our first question, and that is one of our audience members asks, I find that post-acute care organizations, i.e. nursing homes, are far behind in EMRs and interoperability with those that do have EMRs. What do you see in the near future for this area?
Wow, that's a question that hits home with me because I've been going back and forth between a specific state, caring for my mother for 18 months, even though she's in a state-of-the-art retirement complex that has independent living, homes, apartments, a health center, and assisted living. Yeah, from an EMR standpoint, it's scary. I feel like it's gone back when I first ran a health department in the state of Florida. I can still visualize the eons of paper records. I think, sadly, it's going to take the physician community in each area to become liaisons with these centers and drive this in the insistence of better coordination of information. The number of times I could tell you that my mother has had tests and procedures, and each is considered such a separate incident that they don't even have a total view, and let alone getting information back to their primary care physician. So it's critical that as physicians start realizing the art of the possible and managing their business better, that they start demanding more from the post-acute care centers that are in their community.
Okay, great. We're just about at the top of the hour, so we're going to take one more question and then wrap it up. So our next question is, how does a health system determine which data sources or suppliers will deliver the best return on investment?
That's a great answer. I'm going to start it off and let Jim kind of add a little to it. I think the first and foremost thing I would ask is if you're looking at suppliers of data that lean mostly on telephonic outreach, and therefore the game plan is to reach out and maybe hire somebody to do that outreach, and then they surface the data and build it into spreadsheets that can be used. That's one approach, but the real critical approach that we believe is the first and foremost is to leverage the data that's already there in an automated fashion such that you're not recreating the wheel. So much information can be gleaned from existing public record data, our medical records claims, our largest warehouse of physician data. That information kind of tees it up for the work that then needs to take place. Jim, do you have anything you want to add to that?
No, I think that's a good answer, Rick. I mean, I think I would start at a simple level, looking at a data source and looking at, how does it overlap with other sources you have? How accurate is it compared to the other sources that have, and is it a source that you can trust? So a lot of the work that we do in working with the customers is helping with those evaluations, and of course providing a source of truth where we've done all that work to try to integrate data sources that are relevant to healthcare and then making them available to our customers.
And with that, I just want to thank everybody for their attention and time, and we look forward to future discussions with you as you work to factor in new sources of information and thrive in the world of new care payment and delivery models. Thank you and have a great afternoon.
Okay, thank you very much, Rick and Jim. We really appreciate it. Ladies and gentlemen, you do see the contact information for our speakers up there on the slide. The last thing I do want to mention, after the webinar, you will be receiving a communication with a link to the webinar recording as well as a copy of the slides. We do want to make one final thank you note to LexisNexis Healthcare for sponsoring this event. We really do appreciate it. And we want to thank all of you who attended this program. We appreciate your presence with us, and we hope that you'll join us for a future web seminar. I'm Mike Perkowski. Thank you very much for joining us. Have a great day, everybody.